So I am Dr. Megan Clark. I am the faculty co-chair of our St. John's CRS Global Campus Committee. And I want to welcome you all here for an unfortunately pressing and timely conversation about what's at stake with all of the debate about USAID and foreign aid, and in particular with a focus on HIV/AIDS and global health. I will begin, as we always do here at St. John's, with a prayer. And today we're going to begin with Catholic Relief Services prayer for this month, which is the prayer to the Good Shepherd. Lord, my shepherd, I have known death, and you have refreshed my soul. I have known fear, and you have comforted me. I have known hunger, and you have set a feast before me. In the darkest valley, no calamity of humankind or nature has separated us. Teach me to walk as you walk, beside those in mourning, so they will know joy, beside those in fear, so they will know comfort, beside those in hunger, so that they will feast until their cup overflows. As your goodness and love follow me, may mine follow my neighbor, so that the threats of the worst terrors may turn to the knowledge of the comforts of the house of the Lord, where you have invited us to dwell forever. And so let me strive to help build on earth what you have promised us in heaven. In the face of all calamity, present and yet to come, let me lead my neighbor beside quiet waters, the quiet waters of the Good Shepherd. Amen. We are privileged today to have with us three experts, all of whom are on the front lines of this situation. And so a little bit about why we are here and who they are. So we are here today having this conversation because you hopefully will have seen in the news that USAID, which is the US federal government's humanitarian aid and development organization, has largely been stopped and defunded. Existing contracts have been canceled. Existing bills have just gone to the Supreme Court in order to demand that bills have to be paid for services provided already to some of the poorest around the world. USAID provides, and our foreign aid provides, medication, food aid for the hungry, and a whole host of education programs. It really is a diverse list. But today we're going to be focusing in particular on some of the impacts of what it means to freeze or withdraw USAID funding with respect to global health. One particular element that you'll see a lot about in the news that is really important is Pepfar, and that is the President's Emergency Funding for HIV/AIDS. This is how it was a program that came about under George W. Bush, and millions of people have received HIV/AIDS medication, antiretrovirals, TB treatment, and really this program has helped us move from HIV/AIDS as a death sentence to HIV/AIDS as something that is, in large parts, if you can access the medication, it can essentially be a chronic illness where we can prevent almost all transmission from mother to baby, and people can live lives that are reasonably close to the same, if not the same, life expectancy. Again, if you have access to the medication. I am pausing for a second. Are those who are watching able to hear me? One person has put in the chat that they can't. And so I just want to make sure, okay, if others can, then Ms. Lynn, it's something with your computer that is at stake, but I appreciate the notice, because if nobody could hear me except for the speakers, then we would want to fix that technical problem right away. And so at stake in the question of USAID and Pepfar funding is access to medication that people need in order to survive. This weekend, in the New York Times, Nick has a extended and online, it is interactive, investigative journalism along with the Center for Global Development, looking at what would the impact be if we went one full year without USAID and USAID funding. And what is, quite frankly, likely a conservative estimate, this would mean upwards of 1.6 million deaths from HIV/AIDS, 500,000 from lack of vaccine access, 550,000 from lack of food aid, 290,000 from malaria, and 310,000 from tuberculosis. And you can look at the New York Times website and look at their interactive maps and how they came up with those numbers. But we are talking about issues of life or death. And so to have this conversation and to understand better both what is happening and what is at stake, we have with us three experts, all of whom are really on the front lines of these issues. Sister Irene Mercy Akumu is a daughter of charity in Kenya. She has been program director for Dream Kenya since August 2018. Before that, she was assistant program administrator in Kitale, where she was also worked before that as a social worker. She has a BA and an MA in ethics and organizational leadership from Tangaza University. And as we'll learn, the DREAM program is a cooperative effort on HIV/AIDS that has worked with Pepfar resources between the Daughters of Charity and San Egidio in Africa. We have also with us Kate Oswald, the Chief Policy and Partnership Officer from Partners in Health, and she will correct me, as I think I may have gotten her current title wrong again. She leads a team with a mandate to drive global strategy on Partners in Health policy, advocacy, government accompaniment, and institutional partnership efforts. She's a passionate advocate for universal health care, global health equity, and had more than 14 years of work in Haiti and Liberia with Partners in Health. She earned her MPH in epidemiology and program design and a BA in international development from Brown University, where she has also, over the past 16 years, served as an instructor in their Leadership Institute's Global Health Program. And finally, we have with us Bill O'Keefe from Catholic Relief Services, who is the Executive Vice President for Mission and Mobilization, who oversees CRS's efforts to build a movement of Catholics and others of goodwill to support CRS's global mission, focused often on the situation here in the United States. These efforts have included lobbying Congress and the administration on a range of foreign policy issues and engaging U.S. Catholics in public campaigns to change U.S. foreign policy in ways that promote justice and reduce poverty overseas. Bill O'Keefe received his bachelor's cum laude from Yale University and a master's in public policy from the Kennedy School of Government. He has been working with CRS since 1987 and has been a long friend to St. John's University in particular. We are very grateful to have all three of you here with us today. I asked you three in particular because you each work for NGOs and on social justice that really embody Catholic social teachings, principles of the option for the poor, solidarity, and subsidiarity, working in and with local communities. And in this case in particular, as we'll hear, local participation as being an important part of what is going on. And so as we begin, I want to ask each of you to say a little bit about the work that you do and the organization you work with, starting with Sister Irene. Sister Irene, you are the director of the Dream Center at the Daughters of Charity compound in Langata, Nairobi, which I have had the privilege of visiting. Can you tell us a little bit about the Dream Center and your approach and the work that you do in Nairobi?
Thank you, Megan. Dream Center is an international program offering HIV care and treatment in 6 African countries, run by the Daughters of Charity, that is Mozambique, Nigeria, Kenya, Tanzania, Cameroon, and Congo. In collaboration with the St. Egidio, which is a lay Catholic community in Rome, they help us develop the software, that is the software that we use for treatment. And then the program was first launched in 2008. We started with only 100 patients. Now we have over 3,400 patients as per now. And what we do mostly, we do care and treatment, that is counseling, HIV counseling and testing. We do provision of the drugs, that is the ARVs. We do diagnosis and treatment of opportunistic infections like malaria or tuberculosis or any other infection. We have the lab services. We do elimination of mother-to-child transmission. We do tuberculosis screening and treatment. We do cervical cancer screening and treatment. We do psychosocial support because these patients, they need somebody to journey with. So when they come here, we have to journey with them from the time they are tested positive until they get used to the treatment. We do nutrition counseling, and also we provide food. It's a prescription for those who have low viral load. So we also give them some food, and also for children who are underweight, and also for pregnant mothers who are also not doing well. So it's our program, the approach here is patient-centered, where all the package we offer it's towards the patients, because some of the patients here are from poor background. We have variety of patients because HIV it's like free treatment, so we cannot discriminate people coming in. So we offer this treatment for everybody. We do more of community outreaches and also free medical camps because some people, they cannot reach the center. So we take the treatment to them, not specifically of HIV treatment or testing. We try to give them any other services, treatment that they need. And it has made us to go to the villages that people have never even imagined, like 11 hours drive from Nairobi, to offer treatment to the Maasai people who don't even think that they can go to the hospital. And so that services we offer here doesn't only remain here. We move outside of the Nairobi also, because our patients, they are from everywhere. HIV, they can't be like, anybody is free to go to any hospital where they want. So we have patients from different counties. Even two of our patients, they live in the US, but they come yearly here for their treatment. So so we try also to give freedom to the people. If they want to take treatment here, then we do that for them. So it's a center that I would say it's friendly. We value our patients so much, and also we make it a home for them because of where they're coming from. Yeah, thank you.
Thank you, Sister Irene. And I noticed Kate and I both smiling when you said 2 patients from the US come back to continue their treatment in Nairobi. And I can't help but think that the late Paul Farmer would enjoy that. He frequently said that accompaniment that was coming out of programs like Dream and spearheaded by Partners in Health delivered better care than often impersonal kind of following can be and cost here in the United States. Bill, turning to you, Catholic Relief Services is the official international development arm for the United States Roman Catholic Church. Can you briefly say a little bit about what that means practically, and situate CRS in this context?
Absolutely. First, it's an honor for me to be here, and thanks for raising these really important topics. So, um, first of all, what I'd say is for every Catholic in the United States, they should know that they have an organization that in over 120 countries is doing the work of the gospel on their behalf and is meeting humanitarian need, is responding to disasters and emergencies, helping small farmers to grow food more efficiently and effectively to earn a living for their families, providing basic education for kids, helping women and take care of their families, and addressing the scourge of HIV, helping church institutions to meet the needs of their populations. We've been around since 1943, and it's really an incredible honor for me to represent them and to some of our important constituents here, Catholics who are part of the CRS family. Um, about half of our assistance is originally comes from the U.S. government, and so we're part of this conversation right now because about 83% of the total U.S. government projects have been terminated and from USAID, and I would say of ours, it's a little more than half. And millions of people, we estimate 20 million people who are getting assistance right now are not going to be able to unless we can find a solution to this problem. So that's who CRS is. That's why I'm here. I'm responsible for the sort of small chunk of CRS that tries to get the U.S. government to learn from our experience from around the world and adopt more just policies that address global poverty. And we're fighting the good fight, but it's a fight.
Thank you, Bill. And for those who aren't aware, this committee and webinars like this exist as an outgrowth of St. John's longstanding partnership with Catholic Relief Services, in which our professors and CRS work together when we can and try and mobilize our students when possible. But we've been in a wonderful partnership for probably 20 years now, between St. John's and CRS. Kate, turning to you, Partners in Health is, while it is not a Catholic organization, but is a secular organization, it is a secular organization that was founded with a deep commitment to out of the Catholic understanding of the option for the poor and demanding that absolutely everyone is entitled to good quality health care, that is what human dignity means, no matter where you live, whether it's in rural Haiti, Rwanda, or Boston. And you are leaders in global health and human rights, known for this commitment of the highest standard of care. Can you say a little bit about how PIH goes about doing that, and your work, and situate you guys in this conversation?
Sure, absolutely. You did such a beautiful job giving the overview. Thank you. I will just build from that. It's always wonderful to know partners who can articulate your mission and your values better than you can. Thank you, Megan. Professor Clark. Building from what you said, I think when you lead with the patient perspective, the community as the center of the work, it's easy to imagine that everyone should have access to the same highest quality of care, the tools that of modern science that we've all worked so hard at as academia and to develop, and industry to develop. And so Partners in Health we exist to work with governments, to partner with communities to help ensure that those resources are transferred to those who are most proximate to the suffering. And we do that through, a holistic approach, very similar to much of what Sister Irene was explaining in terms of the comprehensive, patient-centered, ensuring that it's not just medicine, but food, housing, the necessary social supports, transportation fees to be able to access care are included as part of the package of services that are available. And over the last 30 years, we've been able to grow and expand the work that we do beyond HIV and TB services to mental health and surgical services and oncology services, because the backbone of the health system, the staff and the human resources, many of the supplies and the equipment that you need to be, that Sister Irene noted, that are necessary to keep people alive. The systems for transporting lab samples to and from facilities, the supply chains that were ensuring that meds actually got to a facility, or even far to the remote communities where vaccines are provided. All of those things were available because of the support of programming like Pepfar and US government support. And so, we are here today because those programs have existed. We could use them as that backbone of health system strengthening to reinforce. And so today, our work is meant to complement, not supplement, not supplant existing health services. And so we do that through through that work, but also are deeply concerned by what's happening around us, because, as Bill noted, while we were lucky in the sense that we don't have half of our funding coming from U.S. government sources, the communities around us and the layers of impact beyond where we serve are deep. We're just starting to understand and unravel those layers of impact. And we know that, and we don't want to become islands in the communities that we serve. So we have to work really hard in partnership with CRS and so many other colleagues to accompany our communities and our governments to advocate for sustaining some of these programs in any way that we can.
Thank you. And we are at a critical moment. We're at a critical moment where I think where not only do we risk moving backwards on real gains that happened in terms of global health and lives of people, but also we're at a moment where the US population, whether it be our students or the general public more broadly, I do want to say, I don't think a lot of people really understand what USAID is. And I don't think they really understand. And so I'd like to kind of pause for a little bit here, because I think there is something wherein, we've seen a lot of headlines claiming that USAID is or does things that that may sound objectionable, but when you actually scratch at the surface, none of those kind of fear-mongering actually are borne out in what it is that kind of USAID programs are doing and funding. And if you are a supporter of Catholic Relief Services, one of the most frequent legislative alerts that you get every single year is asking you to call your representatives in support of the foreign aid budget, in support of increasing it and not lowering it. And so I want to kind of start there in terms of the question of where we are now with Bill. And one of the things back when we first met, your key role was in negotiating with the government and lobbying on foreign aid. In the many roles you have had, you have spent decades negotiating and pushing for foreign aid and USAID funding within the United States budget. Can you say a little bit more about what USAID is and how we advocate for it and how it gets used? And some of these grants at CRS that are at risk are health, but some of them also are some other things. So if you could just give us a little bit of a picture of what you lobby for when you lobby for foreign aid.
Yeah. Great. First is Americans do not understand the good work that is being done by their government around the world and the history. And Pepfar, frankly, is the best example. 25 million lives have been saved since 2003 in an incredibly innovative and American response to a problem that was metastasizing faster than we could catch up. And it just is amazing how our country has helped to turn that around. And we should feel good about foreign aid in that way, but we don't know enough, frankly, most of us, in order to do so. USAID is a part of the federal government. It's semi-independent, organized under the State Department, and its job basically is to advance U.S. national interests through helping other people in other countries to develop themselves in the long term. There's always been, in the original vision of USAID, of course, it's the American government does this to benefit the American people, but the long-term knowledge is that it's by helping other people that in the long run we ourselves will benefit. So TRS, as I said, gets half or a little more of our assistance from the U.S. government. A lot of what USAID does is the kind of stuff that CRS does, and that Partners in Health is involved in, these kinds of global health, human development, emergency assistance. There are other things that we're not involved in. So CRS, for example, advocates for about half of the USAID budget specifically. We don't advocate against the rest necessarily. We don't really know anything about it, but we advocate for the half that's focused on people and addressing poverty. And frankly, it's a very effective long-term effort. It's also an important thing to note is historically, it's been very bipartisan. The parties come at it have some different perspectives, but generally it's been an area, even in these toxic partisan times, where we've been able to build bipartisan consensus, because Americans do want to help other people. They really do. If you talk with people, they will say, and you say, look, there's 24 million people hungry in Sudan. Should we do anything? They're going to say, wow, if we can do something, of course we do something. And the question of how has just not been communicated well enough by, I think, our leadership in the country in a way that they feel connected, Americans feel connected to it. But it is traditionally very bipartisan. It is true, Megan, as you said, there's a whole bunch of disinformation out there. There are these examples of things, and I know I'm talking to a lot of students. You know better than I do the social media environment we're in, where a little meme with some outrageous statement gets millions of likes and circulated all over the world, and the long explanation of why that isn't true goes nowhere. So that USAID really has a challenge, as there are those who are trying to prevent this kind of work from happening, taking an example, blowing it out of proportion, and distributing it around the world. And what I can say is that the vast majority of this work is helping millions of people in a way that Americans would feel proud of. And it's just much harder to tell that story than, some kooky example that somebody can blow up and put on a social media meme. I think that gives you a pretty good sense. I think it's really supported by the church too. Church is very strong. Pope Paul VI in Populorum Progressio talked about how the moral responsibility of wealthy nations to assist more vulnerable nations, and just as a principle of justice, we have a responsibility to to help our brothers and sisters who are part of our one human family to develop. Of course, it's in our own interest, but that's not why we as Catholics do it, but it is why our government does it. And I think there's a kind of a happy marriage there. So I hope that's helpful, Megan. Happy to talk more.
No, this is helpful. And I think part of what because the United States is so large, and because we are we're not, we are a wealthy nation, a highly developed nation, but we're also one of the largest just actual countries, nation states in the world. And so the reality of, say, the United States government and the United States budget, I think oftentimes is just too big for most people to even kind of fathom. Right? We don't often think about the fact that the state of California alone, if it was its own country, would be, I think, the last time I checked, the 5th largest economy on the planet. And that's just one US state. Now, right, our largest, and so I think, I think you're right. We don't know the stories. And also people think the USAID and the development and the foreign aid budget is a big thing, when in reality, it is a fraction. It's, barely 0.5% of the overall US budget. And so we don't, the good work that it doesn't cost or take away from anything that could ever be done domestically, because it's not even 0.5% of the overall US budget. And so I think we're often dealing with something that can feel so abstract from the US side, and right is a decimal point, right, is negligible to the overall US budget. But for the people that it impacts and the places it goes and the programs it supports, we are really talking about a life and death reality. And Pepfar is a really great example of success, but it's also a really great example of how, the kind of the question of US interests and the question of doing the right thing, of access to top quality healthcare, access to the healthcare you need for those who can't afford it, has been really clear, because the vast majority, if not all, of the medications that are purchased by Pepfar or accessed via Pepfar, is the U.S. pharmaceutical companies are a key part of that. And so we often don't even recognize that the intersections. This is also true when it comes to food aid. A lot of the food that goes as part of hunger support is food that we're hearing now from the American Midwest, of the question of food that is being harvested in places like Iowa, that now nobody knows what's going to happen to it, but that it is slated in order to be part of food aid. But kind of focusing in on the Pepfar component. Kate, you noted when you did your overview of Partners in Health that Pepfar really, right? So Pepfar really comes at a time, right, that allows Partners in Health to kind of develop and establish itself and build in the way that it does, precisely because it made what Partners in Health did, and then we later see with the DREAM programs and ones like it, possible. Can you explain a little bit about Pepfar and the impact it's had on the global HIV/AIDS pandemic?
Sure. Yeah, when we've been talking with some of our advocate friends who now have gray hair and are having to stand and do the same fights that they were doing 30 years ago, in die-ins, and demonstrating that every life is important, that every person is a person. It makes you realize that in 5+ years since it started in 2003, 22 years, I can do math. You know, as Bill noted, the 25 million lives that it's saved from HIV alone, let alone all of the layers of additional impact that it's had on, you know, stabilizing health systems. It's been extremely important for our ability to kind of translate a small, you know, project. We started in Haiti in the late 90s to provide antiretroviral therapy when it wasn't yet available, before Pepfar was a thing. And to, you know, one of the first articles that was published by Dr. Farmer and our Haitian colleagues, many of whom still work with us running programs all around the world, demonstrated that the first 50 patients who successfully stayed on treatment, and that programmed data helped influence, you know, the creation of the Global Fund, which came first, the Global Fund to fight HIV, TB, malaria, and then, you know, of course, there were many others that were part of the equation, but also helped to demonstrate that it is possible in remote rural areas to have patients stay on antiretrovirals and survive. And some of those patients are still alive today from that original 50 cohort, and they lead some of our patient advocacy groups and patient treatment in Haiti today, even in the midst of all of the challenges that Haiti as a country is facing. So Pepfar, we called it a battle horse, a cheval bataille, because it didn't only you know, center on vertical programming for, you know, stopping the, you know, the spread of HIV, preventing and then treating, but it also allowed, as I was noting, the, you know, this backbone of you need laboratory services if you're going to be able to diagnose. You need to have you know, treatment for opportunistic infections, as Sister Irene was noting. And so it really, over time, has allowed for governments to be able to help spread their extremely scarce resources to reach, you know, more of a holistic health system. And for us, it was essential because it didn't only allow us to, you know, to demonstrate what was possible in Haiti, but, you know, in the early 2000s, the governments, as Pepfar was coming about, the governments of Rwanda and Malawi and Lesotho and others said, help us, come, show what's working in Haiti. And a number of our Haitian colleagues started those programs. And now, of course, 20+ years later, the governments had been, you know, with Pepfar funding, managing all of that work. And what's been, I'll wrap up, but by, you know, I think what's been essential is that ability for stability. And, you know, as we've been celebrating, you know, as the International AIDS Society conferences and all of us participate, the advancements that have been made, as you were saying in the beginning, you know, HIV has become a chronic disease. And now, you know, people are dying from other non-communicable diseases, such as cancers and heart disease and things that we see in this country. But that's because of that ability to have constant medication. Without that constant medication, we know that resistance quickly happens. And even a few weeks, a few days of missed doses can be life or death for some patients, because every individual ecosystem, you know, human body is different. And so, you know, we are deeply worried about, you know, about antimicrobial resistance. Obviously, HIV is a virus, but TB with bacteria and such. So we, you know, we're deeply tracking that and working with our government counterparts and partners at Global Fund and elsewhere to ensure that, you know, as possible, even if staff are no longer in places, that patients are, you know, receiving their medications and supplies.
Thank you. One of the things that has always struck me is the stability part of it, right? That the stability part is central for treatment of a disease, right, in terms of managing, but also in terms of the building of healthcare systems more broadly. I read recently in all of this that at this point, right, an awful lot has been, right, so Pepfar, the US funding for Pepfar is one part of it, but that over the last 20 something years, right, we've seen the countries that receive Pepfar funding, receive the medication and the support, right, they have been building their infrastructure, right? It has been a success in many, in structurally as well. And so that we now have, I think it was in South Africa, 75% of the treatment and the programs and the access to medication for HIV/AIDS is taken on by the South African government. And it's only this fraction now, right? So where when it started, it may have been reversed, or places may have been almost entirely US funded. Now, right, countries have been taking, but if you take out, the stability rests on kind of the whole kind of system. And if you take out 25% of the support for any aspect of managing HIV/AIDS, and you take out just that bit, kind of the ability to continue to kind of control the HIV/AIDS pandemic and continue to the global health gains starts to fall apart in dangerous ways. One of the things that I think, again, Pepfar and HIV/AIDS provide a very good example of as we think about global health equity, and this is where I'll turn to Sister Irene, is the fact that it is absolutely about providing testing and medication, but it is never just about providing testing and medication. And there is something here that I think it really does provide a window, not just to kind of the approach of the three organizations on here, of CRS, of PIH, and of DREAM, but of really, right, the Catholic understanding of human dignity as it applies to questions of health and human flourishing more broadly. And so I want to ask you to share a little bit more about practically on the ground what DREAM means for your patients, and how the holistic care that you deliver has an impact, yes, on their specific health, but more broadly on their health and the community as well.
Thank you, Megan. I forgot to share that all our services here are free of charge. Patients, all our 3,400 and something patients, they all receive services here free of charge. And that also explains why the Pepfar is so important for us, because we get like medicine, the drugs, the HIV test kits, immunization, vaccine for immunization for children. We get the lab reagents from the government, but through the USAID. And then for the part of Pepfar, it funds an organization that pays all the salaries for all our staff, who are 43. And also it offers some of the reagents for like cervical cancer screening, some of the services like transport for patients who are bedridden. We do a lot of home visit also, but that all requires money. You can imagine a program that offers free services. But also we've tried to source out some of the funds, as Kate said, from outside the country, because Pepfar and USAID cannot offer 100% to our services. But as Kate mentioned, the medication for patients, it's constant. You cannot stop. When they start, they need to continue with it. And that worries me most of the time, because if they stop, then the rate of death will be high. Many people will die. We'll go back, Kenya will go back to 20 years when people were sick in the hospitals. There is no medication. The government doesn't have the capacity to buy such drugs for our patients here. So though the government always tells us that it can provide, but as we live in Kenya, we know that it's not that way. But now Pepfar comes in as a support for us. and we can't ignore what they do. We can't ignore what the USAID is helping us to for our patients, because when a patient comes here, they are bedridden. We need to offer a holistic package for them. From the time they enter the compound, they need to be given the drugs. You need to give them like nutrition supplements, which comes from the USAID through the Ministry of Health. So we really rely on it because it will be sad for me when we go back to where patients will die in the houses or in the hospitals, nobody to care for them, and nobody cares even if they're dying or not. So it's sad if the funds end and then we start again to try and help these people. Those who are rich, they'll be able to buy drugs. But what about the poor people who even don't have transport to come to the facility for their appointments, for their treatment? So we appreciate, at the moment, we appreciate what Pepfar is doing for us. We have the drugs for our patients for almost like 3 or 6 months. We won't lack, but when they stop, then all the 3,000 patients here will have to look for alternative means to get their drugs.
And it's helpful and it's important because it's not, right, it's not abstract numbers. It's not dollars and cents. It's lives, right? And right, it's 3,400 people that you know. And right, and that gets multiplied out in the other dream centers in, you know, across with Partners in Health and Sierra, right, across, and again, not just sub-Saharan Africa, but globally. And you know, these are people, these are lives. And I think you noted that what I think is the big fear for those like you who are on the ground treating patients now, and those like those Kate and Bill mentioned who have been, right, who remember, right, who were part of advocating for this in the first place, is the fact that we have all seen what it looks like without the medication. We've seen what happens when the medication's not there, when you can't the test kits aren't there, when the nutritional support and the wider social support isn't there. When we go, right, the big risk that my mother is a newborn nurse practitioner, right? The going back to a world in which mother to baby transmission spikes again after the gains that we've made, right? And as a moral theologian, right, now we know what to do. We know how to stop it. And so what's at stake in terms of moral culpability, our responsibility, is much greater because it's a choice to go back, and not a choice by the poor, right? Not a choice by those who need this, but a choice by the United States government, which, whether one likes it or not, is the elected representative of every U.S. citizen, and therefore is doing, you know, is making this decision in our name. Again, even if you disagree with it, even if you're making, you know, I encourage people to make their voices heard, but it is, right? It is an active choice to go backwards. The impact of the interruptions and cancellations, we know what it will mean, and this is what the New York Times article this weekend was very helpful. We know what it'll mean for today's patients. The other element that I don't think everybody understands, and I want to ask Kate to say a little bit on this, because Pepfar is involved in not just care, but research and research advocacy, is that the impact isn't just on patients now, but it's also going to very quickly start to impact our medical research, clinical trials, and the future of our ability to kind of progress our care and our treatments as these viruses, bacteria, and diseases progress. So what is at stake in terms of our medical development with interruptions and cancellations of our research and USAID funding?
So much. That's I'm just going to qualify it as so much. On the TB side, we've been celebrating the fact that for the first time in decades, there are more than one new candidates for a TB vaccine. And while that money wasn't directly coming from Pepfar itself, it was coming from bilateral TB funding, the same funding that we're talking about that goes to U.S. foreign assistance. There's a line item that's specifically for bilateral tuberculosis support. And we had some of our lead scientists and colleagues at the global forum to celebrate these vaccines back in November. And now the next phase, the phase 3, to bring them to actual fruition is necessary to actually make it from a trial to reality. And so we hope there will be other partners that step in to fill that gap in the short term. But to imagine that after all these decades, with TB being one of the oldest known diseases, and still, now that COVID has kind of is around in the ecosystem, TB has taken back its infamous name of being the top killer of infectious diseases in the world, something that we never want to celebrate. And so these trials were so critical because, we're imagining a world where ending TB is possible. If the vaccine and all the other tools that we've mentioned, new diagnostics, better treatment regimens, that whole cascade are available. The same is true, for decades of work that's gone into HIV vaccine work and better treatments, and the new long-lasting PrEP, which is a prophylaxis for people to prevent themselves from being potentially being exposed to HIV and becoming sick. All of this has been advancing significantly. And, we as leaders were excited to find ways to incorporate it into our programming. And if those programs do not exist now to procure those meds and ensure that they get into the countries where we are and then to our patients, like we've been saying all throughout this, we'll go back decades. And that's just tragic, as you were noting, this moral responsibility or culpability. So I hope that gave a bit of a picture. Sure, others could add.
It is both it's both exciting to imagine a TB vaccine and terrifying to consider the fact that we could be on the verge of one and simply walk away from it. And this is one area where, as you note, you said that you hope someone in the short term, others will step into the gap. And we've seen a couple of places where the example in my head is not on global health, but on the environment. And when the United States withdrew from the Paris Accords, for example, Michael Bloomberg came out and said he would insert what the U.S. contribution was that was disappearing from the UN efforts on the Paris Accord. But that's right. That's one item, right? As opposed to in one area. We've heard a little bit, and Bill, you mentioned that kind of the interruptions, cancellations of USAID grants, both existing and future questions, will have a large impact on CRS and many other organizations. And I do not intend to put you on the spot here, but one thing you hear people say, right, is in terms of filling in the gap, is that, well, this stuff is all just philanthropy, and faith-based groups will just, right, people of faith and faith-based organizations and churches will just step up, right, can just insert, and the government doesn't need to be doing this. Is it possible for faith communities in the United States to simply make up the difference here, and we don't need the government? Why do we need the government involved? And you mentioned a little bit, but I would also say, if you want to add anything about why, from your perspective, for Catholics, the government being involved is a justice matter.
So The first thing is, I mean, we get lots of support from generous Americans, generous American Catholics, and others already, and there's absolutely no doubt that it's a critical part of what we depend on, and it actually allows us to do some of the more innovative work because it comes with fewer strings attached and things like that. However, there is no source of resources at the scale of the government. And even these huge foundations that are like Mr. Bloomberg stepping in on climate change, it's great that he did that, and he'll be able to do that for a short period of time. He can't do that indefinitely, and there aren't enough, sort of people like him, for better or for worse, who would step up and fill those gaps, even for short periods of time. So the truth of the matter is, the government is by far the largest source of resources going into humanitarian and development response. It's also where these resources can be directed and organized, like for Pepfar, for a key purpose. The other thing I'll say is, as a American believer in democracy, the thing about a bipartisan program like Pepfar is it actually does represent the range of views of the American people. It was developed over time through a political process and therefore has the legitimacy that comes from that. And so to kind of sit back and think, well, maybe a couple billionaires out of the generosity of their heart will sort of make the right decision. I just don't have trust. It's not that there aren't good billionaires out there, there are, but I just think as a way of making the world a better place, I'm not willing to rely on that as a model. Um, so the first thing is our government really is where the resources are in order to organize the kind of response that needs to happen. The second thing is, we as Catholics do believe that governments have responsibilities. We're not libertarians. We do not believe that the government is only responsible for, providing the Defense Department. It has responsibilities for the common good. That's why we actually, in Catholic teaching, that's why there is a government to provide for the common good. And the common good is not just for citizens in Catholic teaching. It is for the whole human family. And I would finally say, you know, what is the point of being the richest, most powerful country in the world if you're just going to sit on your gold like some sort of dragon in the Lord of the Rings? I mean, the whole point of having is to share and to use what one has for the betterment of others. We all know that when you do that, it comes back. And Pepfar is a great example of this. I mean, we are a much safer, healthier country because of Pepfar. And um, and we're safer and healthier because the countries that literally, when I was working on this in the 90s, when they were about to collapse, because all the healthy reproductive age people were going to die, that didn't happen. And thank God, we are a safer, better world as a result. And so we need to kind of keep our heads here and realize that doing the right thing is also the smart thing, and we can do that. So we need to push back and get our government back on task here.
To your point about the kind of looking back in the 90s and then where we are now, one of a professor of anthropology here at St. John's put in the chat, wondering of the multi-generational repercussions of all of this. And we talked about, I brought up how it would affect health, but that what we saw in the 90s was a wave of orphans. One of the things that was a lot of programs, many of them run by Catholic women religious, that put together, right, grandparents and children, because an entire generation of parents, right, died too young before we had access to ARVs, before they were developed, and before Pepfar. And so the kind of interruption of this one multi-generational poverty is at stake. Because if you impact, it again, it's not just the people who are sick now, but it has wider implications. Sister Irene, I want to ask you, as we think about our students who are on here and who will watch it later, what would you hope that American college students would understand about the situation and of HIV/AIDS and healthcare in Kenya, in your community, the patients you care for, and the importance of programs like DREAM? What would you hope that our students would kind of come away understanding about the DREAM program and your community in particular?
When we had the report that the program might end, the place was full of people. They all came here to pick their drugs for 3 months, for 6 months, and they were begging for us to give them more drugs. And then we had to put up strategies on how can we reach the poor people in the village who cannot come here. We had to send drugs. We had to go to the villages to collect blood samples, to bring them back to the lab here and test the viral load test or CD4 count, just to use the reagents that we are having before everything is closed down. So the program here serves mostly the vulnerable. That was the initial reason why the program was started. And most of our patients who come here, they don't even have like transport, as I said. So the DREAM program is very important to the people here, though it's in the capital city of Kenya, but the poverty around here, it's high. So we cater for these people. And as a daughter of charity, we serve mostly people who are living in poverty. So we try to provide them with quality services, that is the treatment, just the same as we provide for those who are able to buy drugs, because we don't want to discriminate them because the way they look like. And that is the aim of the DREAM program, because we want to offer this holistic, comprehensive service to these people without minding where they come from or their background. So the aid from the US is very important for us, because I imagine a situation where Pepfar or USAID decide there's no drugs. What will happen? How many people will die? How many children will be infected? Because we try here to have zero transmission from mother to child. That is our motto here. But when the drugs we had those issues in February, January, we had even to keep drugs for all our pregnant mothers, because we don't want the infection. We don't want the transmission. We were so worried. Everybody was like, all the staff were like, I have this patient, I know her. Can I keep drugs for them? This patient is challenged physically. Can I keep drugs for them? So, but we as a group here, as a DREAM family, we discussed that we'll offer equal services to all our patients. And also we put categories of those who are vulnerable, so that we can reach them before the drugs end or the funds stopped. But luckily, the fund is still going on until maybe September. We are not sure from September. So at the moment, we have the drugs, we have the reagents. But now when September comes, it's in the hands of God. We don't know what's going to happen from September. Yeah, thank you.
Thank you. One way that one way that everybody who is watching this webinar can help on God's behalf is by clicking on the link in the chat and making sure that your representatives support continuing and restoring Pepfar and USAID funding. That is the CRS action item link. They make it very easy. You put in your address and it populates with who your representatives are. In addition to contacting your representatives, I want to just ask Bill and Kate, is there one other thing that you would suggest that our students can do in order to support this effort?
I can go first, and just because you mentioned me first, but I think the second thing is talk to your friends, and and talk to your friends on social media, and take that action alert and put it out on social media, and you know, um, this is a moral outrage. The fact that there are children who could be born with HIV who don't need to be, and therefore their entire life trajectory is going to be changed in a way that doesn't have to be because sister is unable to provide the drugs that our country has committed to provide is a moral outrage. And that, Partners in Health is going to be in a variety of different countries, providing doctors that are witnessing this and are going to be unable to do their part. And CRS and other groups are supporting these good folks and other church institutions, and are going to have to pull back on that support. It's frankly unnecessary. Any administration that comes in should take a review and take a look and take some time and figure out what's working, what's not. That's all good. But stopping things midstream that are life saving and then doing so in a way that doesn't provide for their for an orderly continuation or process is just unconscionable. So talk to your friends. This is one of these earworms. Once you hear it, it has to kind of come out, and so let it come out of your mouth as you talk to your friends. Thanks.
Yeah, nothing more to add. I was going to say the exact same thing. Just educate yourself. Really read up on these issues. Don't. I know it's really. This is all so deep and tragic and upsetting. And the easiest thing is to just ignore it. But please don't. And do continue to educate yourself and share about the moral outrage. Thank you.
Thank you. And I know that everybody who is watching joins me in thanking Sister Irene, Bill, and Kate for spending your time and sharing your wisdom and information with us. One way that also is once this goes up on YouTube, share it with your friends so that they too can learn a little bit more about Pepfar and USAID and CRS and Partners in Health and the work at the Dream Center. As all of you know, the Daughters of Charity are the sisters founded by St. Vincent de Paul and St. Louise de Marillac. So they are part of our Vincentian community here at St. John's University. I am very grateful for their time today. And I hope that many of you will be able to join us on March 27th as we hear from Dr. Steve Schneck about the situation of international religious freedom and what it means for religious minorities in other countries in this particular moment. And he'll engage a couple of students in kind of a big picture of what's going on around the world. Everyone have a wonderful afternoon. And again, share this when it goes up. Thank you very much.
Thank you.